Good evening, everybody, and welcome to ICON's Facebook Live session on prostate cancer. For those of you who might be joining our Facebook Live series for the first time, my name's Ian Irving. I'm ICON's Group Medical Director, and I'm also a practicing haematologist at ICON Cancer Centre in Wesley in Brisbane. As a haematologist, prostate cancer is not my area of expertise, but we're joined by some prostate cancer experts tonight, and it really should be an excellent session. Unfortunately, prostate cancer is the commonest cancer that is afflicting men, and everyone, particularly as we all hopefully live longer and healthier lives, is at risk of developing prostate cancer. It's a very common cancer. It's a very important topic. And tonight we have three experts who are going to go over the various treatment options and the ins and outs of localized prostate cancer. Just to define that a little bit more, what we mean by localized prostate cancer is cancer that is still within the prostate gland itself, or it may have spread outside of the prostate gland locally, just by direct invasion of surrounding tissues, or even into the lymph nodes within the pelvis. However, when the prostate cancer has spread outside of the pelvis, for example, to the bones or other internal organs, that is metastatic prostate cancer. And we're really not going to be talking about that too much tonight, but to confine our discussions to localized prostate cancer. It's an excellent time now to introduce our three speakers. First of all, we have Associate Professor Jeremy Grummett. Now, Jeremy is the head of department at the Alfred Hospital, head of urology. He has a keen interest in prostate cancer, being one of Australia's leading urological experts on the disorder, particularly an interest in what is one of the latest treatments for prostate cancer, that of focal therapy with brachytherapy, and Professor Grummett very much leading the Liberate trial that we will talk a little bit about tonight.
Thanks, Ian.
Jeremy, thank you so much for joining us.
Thanks very much for having us. Looking forward to our discussion.
Yes, excellent. Also joining Jeremy is ICON's own Dr. Andrew C. Andrew is a senior radiation oncologist with ICON Cancer Centres in Melbourne. He also treats many patients from regional Victoria. He's ICON's state lead in Victoria and Tasmania for radiation oncology. Treats a wide range of cancers, but has a particular interest in prostate cancer. And we very much welcome Andrew tonight together with Jeremy, to provide the full gamut of treatment options and discussions around both radiation therapy and surgery for localized prostate cancer. Thank you, Andrew.
Thanks for the warm welcome. Looking forward to the evening.
Also from sunny Mackay, located in central Queensland, we have ICON's prostate cancer specialist nurse, Miranda Didbin. Now, we all know that cancer care involves a team approach. Multidisciplinary care is what is needed in treating all sorts of cancers. ICON are very pleased to be partnering with the Prostate Cancer Foundation of Australia in having Miranda work with us, as well as Miranda doing her work at Mackay Base Hospital and with other private hospitals in Mackay to provide specialised and expert nursing care, treatment and counselling to patients with prostate cancer. So all the way from Mackay, where of course we have our ICON Cancer Centre in Mackay. Welcome, Miranda.
Thank you very much. Good evening, everybody. And it's very timely to have this meeting tonight with Prostate Cancer Awareness Month. So thank you for inviting me.
Yes, thank you, Miranda. Yes, it's hard to keep track of the calendar sometimes, where every week and every month is dedicated to a different illness or a different cause. And as Miranda said, this month is Prostate Cancer Awareness Month, a very common cancer. And ICON is very pleased to be part of the effort to provide education to the community. We totally understand that many of you tuning in will have been touched by prostate cancer, either personally or in a family member. Certainly, please put forward your questions regarding this topic. We hope to, in the second half of tonight's 1 hour session, get to as many questions as possible. But please remember, we really don't want to be giving out personalised medical advice. When it comes to your personal cancer care, you really do need to discuss treatment decisions with your treating team. So your general practitioner, prostate cancer nurse, radiation oncologist, medical oncologist, or urologist. We really don't want to in any way give out personalised medical advice. But with that introduction, and welcome everyone who's watching. Hopefully you're watching live, but I know a lot of you will also have been picked up the video from the recording that we'll of course put on our website as usual. And we're going to have a discussion back and forward tonight. So I'm going to start by asking our panel some questions, and I'm going to start with Andrew, Dr. Andrew C, our radiation oncologist. And I'd like Andrew to describe what happens when someone is first diagnosed with prostate cancer, and what are the, broadly speaking, an introduction to the treatment modalities that might be discussed at those initial visits.
Oh, thanks, Ian. A very good question. Can I just start by saying that we all are very aware that a prostate cancer diagnosis is probably, one of the most confronting and challenging life events a man can possibly face. And oftentimes with our patients, it's the very first time that they enter, a health arena, not having had operations or contacts with their with medical practitioners previously. But if I can sort of summarise by saying the good news is that the vast majority of men with the diagnosis of prostate cancer, certainly in Australia, do really well. The cure rates are excellent, and we're quite lucky in Australia to have access to high quality care, very comprehensively well-trained staff, both ranging from nursing domains and medical domains. And importantly, what I just wanted to say also is that a prostate cancer diagnosis is rarely a medical emergency. So there is ample time and opportunity to get to understand the disease, get to know your treatment team, to feel comfortable and trusting of that medical team, and also to understand, what your range of treatment options may be. But it's usually the diagnosis of prostate cancer is established by our urological colleagues. Usually there's a suspect that potentially there may be a cancer present. Oftentimes that's from a referral where the PSA blood test was found to be elevated. The next stage is a diagnostic workup that may require some scans. Typically an MRI is undertaken to look at the prostate. Some form of biopsy, which in 2021 is most likely to be a transperineal biopsy, and then some form of staging. That is, once the cancer is detected, we just want to ensure that it is localized, as is the topic of this talk, and not hasn't spread beyond the confines of the pelvis. So the sorts of scans that you might undertake are things like CTs or bone scans, or more recently a scan called the PSMA PET scan, which is a very accurate way of pinpointing sites of involvement. And cut a long story short, there's generally three broad categories of prostate cancer diagnoses that we make when someone is clinically localized. You're either in the green, so it's a low-risk cancer. You're somewhere in the middle, in the amber, where the cancer may be a little bit more virulent. We call that intermediate risk disease. and not oftentimes, but occasionally, you may present with a prostate cancer that is in the red, where it is a little bit more advanced, bulky, and that, depending on where you fall on that spectrum, your treatment options will be risk adapted to match the level, I suppose, of threat that your cancer does pose. But firstly, oftentimes, Ian, the first treatment option that is considered is whether the prostate cancer needs to be treated at all. So if it's in the green, a low-risk cancer, and someone perhaps who even has a significant life expectancy, it's quite possible that that cancer may not ever become significant and may not need any treatment whatsoever. And then if you were to embark on treatment, the two broad ranges of treatment options are either surgery or radiotherapy, and we'll expand upon that, I'm sure, as the night progresses.
No, I think so. And thank you, Andrew. That's excellent. As a follow-up to that question, if you are lucky enough to have your prostate cancer diagnosed early and you're in the green zone, couple of questions just to follow up with you there, Andrew, and then we'll continue down the path. But what is it about those initial tests and biopsy that puts someone in the green zone? And secondly, is it active surveillance? Is that the right terminology for then what transpires after finding a prostate cancer and putting the patient into the green zone?
Yeah, correct. So really the workup involves us interrogating the cancer to get to understand its risk, its biology. Is it slow growing? Is it rapidly growing? Is it not growing? And also how extensive it is. Is it small? Is it palpable? Is it big? Is it impalpable? Is it the size of a cherry pip or the size of an olive, and so forth? Then there are certain risk factors that is your treating doctors will look at that characterise the cancers that we do not think are rapidly growing and don't necessarily pose any immediate health concern, certainly in the short to medium term. And that's low-risk prostate cancer. So these would be patients who have low PSAs, low Gleason scores, and cancers that are quite small. And I think Jeremy probably does see quite a bit of active surveillance in his clinic, so I'd be quite interested to hear what his take is on active surveillance as a treatment option.
That does sound like a good segue over to Jeremy to explain to our audience, but also to myself, what is active surveillance? How does it differ from sort of sitting back doing nothing or watching and waiting? And secondly, Jeremy, to then after explaining active surveillance, if you could then go on to perhaps tell our audience, when is surgery applicable to treat localized prostate cancer? Who is the type of patient who should go on to have a prostatectomy?
Thanks, Ian. And yeah, thanks, Andrew, as well. That is a good segue. I think active surveillance, to some people watching and listening, might sound a bit unusual. I think, when patients get diagnosed with cancer and are, having to process the C word, it might sound a bit strange to actually not intervene and do anything. But I think one of the really important points that we want to get across tonight is that prostate cancer, as Andrew has beautifully described, the green, amber and red zones is a great way to visualise it. And the green zones are as long as they stay green, are harmless. And so active surveillance is the most appropriate option for those. Now, in a grading system, which is how aggressive the cancer looks under the microscope, that would mean Gleason 6 in the older grading system. We're now using, in addition to that, a more modern grading system, and that would be, which is just 1 to 5, and that would be a grade 1 type of cancer where we would predominantly just watch under a process of active surveillance. Now, what does that mean? That's actually a tricky question to answer at the moment because, as Andrew alluded to, there's been so much progress in terms of our imaging. It's been a very exciting time actually in the last few years in prostate cancer. We've gone from doing blind biopsies where we don't really know where the cancer is or even if it's present, and now we've got these beautiful images, whether it's MRI PSMA PET scanning, where we can identify first, is there a tumor in the prostate? And if there is, then when we do the biopsy, we can target that tumor very accurately and really have a very confident sense of what is truly going on in the prostate. And so if that then comes back as low grade, we can be very confident that just observing is the way to go. And that observation really would typically involve a PSA on a regular basis. So for example, 6 monthly, if you've had a very thorough biopsy up front, as you should, then and all you've got is low-grade disease, then a PSA every 6 months would be adequate. What we don't know is how often and when we should be doing further imaging plus or minus further biopsies. That's still a grey area. In the past, we used to do repeat biopsies always at the 12-month mark, but that was before we had MRI, and so we weren't really sure that we were 100% accurate the first time round. So it was almost like a bit of a insurance policy that we weren't missing more cancer. So that's, I guess, a very brief answer for active surveillance. In terms of surgery, so that's really for the amber zone and sometimes for the red zone, if you like. So intermediate risk cancer, which is essentially Gleason 7, and that translates in the new terminology to grade 2 or grade 3. And then the high risk, the red zone, is Gleason 8, 9, 10, or grade 4 to 5 in the new terminology. I know that's confusing, but we're trying to simplify that for patients just to make it easier. So really focusing perhaps on the intermediate cancers, these are the ones that do have the potential to spread, because part of the tumour we know has metastatic potential based on what it looks like under the microscope. You know, when I say metastatic potential, I mean the potential to spread to other parts of the body. So obviously we want to treat with the intent to cure, and the surgery or radiotherapy are the options to do that. So intermediate cancer. Now, sometimes we'll also operate if it's high risk, as long as we think it is operable, in other words, surgically removable entirely, then there are certainly high-risk cases where surgery is appropriate for that as well. But again, radiation is another option for both of those two areas, in fact.
Excellent. That is a fantastic answer, and I think is demystifying a lot of these, as you say, Jeremy, very technical terms. Could I clarify then, for a low-risk prostate cancer in the green zone, as well as a PSA every 6 months, would patients benefit from an MRI scan every 12 months or at some time interval?
The answer, I think, is almost certainly yes. What we don't know is when. I mean, you certainly wouldn't be typically ordering another MRI within 12 months, because if it is low risk, the chance of it changing substantially in that time period is so low. Remembering that these low-grade prostate cancers really are low-grade because they are so slow-growing.
Right. No, excellent. Let's bring in Miranda now. I'd just like to stay focusing for the moment on the low-risk cancers. So this is men who have a prostate cancer diagnosed, often, I guess, incidentally on screening PSA. They've undergone the investigations that Andrew and Jeremy have spoken about, an MRI scan, a biopsy. They've got a low Gleason score. They're in the green zone. They're being treated with active surveillance. And I know from my practice in lymphoma, where we often do observe patients with low-grade lymphoma, some patients and some people love it because they can get on with traveling or their hobbies. Other patients find it very anxiety-provoking because they feel that they have a cancer and nothing is being done about it. Miranda, how do you find men react to being told that they are going to be managed with active surveillance, and what sort of strategies do you explore with them to help keep them well, both physically and psychologically, whilst they're undergoing active surveillance?
Yes, thank you for the question. Yeah, definitely. It's a stressful time for men, just leading up to that point of getting that diagnosis. They've gone through blood testing and they've had biopsies and MRIs, maybe PSMA, PET scan, etc. So there's been a lot going on, and so very stressful time for men and their partners and families. Then once they've got that diagnosis, for some men, it can be a huge relief, of course, to get that low-grade diagnosis. But for others, as you said, they can have ongoing stress and anxiety from knowing that they have got prostate cancer, even though it's low grade. I spend a lot of my time talking to men about what the prostate does and about their disease process, and offering support and reassurance in this case that it is very slow progressing disease, and that by just having active surveillance, we're keeping an eye on things, and they're not actually going to be getting any side effects, which they would get if they actually had treatment. We do know that probably about 20% of those men with this low grade disease may go on to progress later on, but that's delaying effects.
I think we might just be having a few technical issues with the internet services up to central Queensland. There, Miranda, we'll just I'll come back to you in a minute. I think hopefully we're back. As a follow-up, can I ask, when you're talking and counselling to patients who are being treated with active surveillance, what recommendations do you give them about diet and exercise? And does any particular sort of diet or exercise regimen have a place in men with prostate cancer being treated with active surveillance? I think we might have just frozen that in.
Encourage men to eat a healthy, balanced diet, the same as the rest of us, and to exercise. And I'd recommend that not just in active surveillance, but for those men who are having active treatment, and that keeps them strong, and both mentally and physically in the long term. It's also I refer patients off to exercise physiologists where it's needed. Yes. How's the internet going?
I think that's good. No, I think we got that answer out, and that your message of a normal, healthy, balanced diet, with there being no specific prostate cancer diet. You don't have to subscribe to any unusual diets or buy any strange diet-related literature, and exercise is encouraged. And certainly you're right, that is the way for a lot of cancer treatment generally, that combining treatment for cancer with exercise has been shown to be beneficial. Let's go on now to the intermediate zone, and this traffic light analogy really does make it a lot simpler for non-radiation oncologists and non-urologists like myself to understand. So we have a man in the amber zone, so an intermediate grade prostate cancer. Andrew, can you just maybe once again just define for our audience, because there's nothing like repetition about what is it that places someone into the intermediate category? And then secondly, explain to us when would you use radiation therapy, and what sort of men in the amber zone would benefit from radiation therapy?
Sure. Look, thanks very much. Look, just to make the situation slightly more complex, the amber zone is also somewhat of a heterogeneous group of men. So we as prostate specialists do actually divide amber into low risk amber and high risk amber. So again, more colours of the rainbow. That again leads to potentially changes in how we would perceive the cancer and what treatment options we may prefer in some instances. But it does always go back to what is the Gleason score or ISIP grade. So intermediate risk disease primarily is Gleason score 7 or grade group 3, 2 or 3. And that's again the distinction between low amber and high amber. PSAs can be a little bit higher. They might be between 10 and 20. And you may also, when you do a digital rectal examination, which is also part of the assessment in addition to high-tech scans, you may actually be able to feel the cancer. But usually it's small, usually confined to one side of the prostate and not exhibiting what we call extra prostatic extension, which is a cancer that sort of has grown outside the skin of the prostate. And so if you have an aggregate of all these features in your cancer, you'll be then popped into this group. And then not only would we consider, particularly if you had a life expectancy at or beyond 10 years, that you probably do need treatment. And that's when radiotherapy becomes one of the two options that could be considered. Look, oftentimes you do have choice, and we do believe that for men, particularly in the low end of the amber group, you could potentially do very well with radiotherapy, as you could do very well with surgery. And I think if as specialists we pop our hand on our heart and we look at the scientific data, there really isn't any signal from the scientific literature to say that surgery is better or radiotherapy is better. We seem to have reasonably equivalent outcomes at 10 years and 15 years. But the treatments are very different, and that's really the importance in selecting what you think is the right thing for you. And so because all treatments do have side effects and they are different between surgery and radiotherapy, plus individual health factors outside of the disease-related factors, i.e., your general health, whether you have good weight or overweight, whether you have other medical problems, whether the prostate is a little bit obstructed or big or small, whether the surgeons feel perhaps that you may have more risks if you were to endure an open or robotic prostatectomy, then that all is quite influential in choosing choice. Now, radiotherapy, two sorts of treatment, either A, external beam radiotherapy, which is a course of treatment where you would typically attend a radiotherapy department daily for anywhere between 1, 4, occasionally up to 6 or 7 weeks, or brachytherapy. And brachytherapy is an interventional form of radiation where we actually place the radiation inside the actual cancer itself. And because the prostate is very accessible and close to the surface of the perineum, in an analogous way to how the biopsy is taken, we can use the same equipment to insert seeds or radioactive pellets or needles which are radioactive. And they're the two broad treatment options. So I might hand over back to you, Ian.
Yes, I mean, before, and we certainly will hear from Jeremy in a minute. So that was very instructive. Thank you, Andrew. Can I follow that question up with, you did mention that there may be some factors that swing you away from surgery if the patient is felt to be a higher operative risk. They may have other medical conditions, heart disease, lung disease, where it's felt that a major operation is not in their best interest, and that would sway you towards radiation therapy. Are there any other factors, particularly those related to the prostate cancer itself, that would swing you to recommending radiation therapy, external beam radiation therapy, for a patient with prostate cancer?
Look, if you are in that amber zone as such, you probably are appropriate to be considered for both treatments. So really, to differentiate appropriateness for which direction you choose, it does boil down to personal choice, personal preference, taking into account the individual's pre-existing goals, whether it be, my goal is to maintain as optimal sexual health as possible, or, I had a nasty experience and a perforated appendix when I was 16. I never want to go to anywhere near an operating table ever again. Or someone who may have some preconceived ideas about radiotherapy, and particularly, there were certainly in decades gone by quite significant injuries that some more antiquated radiotherapy techniques did inflict on our patients, and corporate memory sometimes certainly persist. And I think it's our job in that circumstance not to tell the patient what treatment to undergo, but to really be in a position to ensure that they are given the accurate and most representative information to make an informed choice, both with their family support and other ancillary support networks.
Excellent, very balanced and fair, and certainly I think Miranda will talk about this a little bit later, but it certainly is recommended that if someone is diagnosed with prostate cancer, that they should consult both with a urologist to discuss possible surgical interventions, as well as with a radiation oncologist, because, as you say, they certainly do have the time, generally, patients with prostate cancer, to make that decision. So, Jeremy, perhaps you could walk us through surgical treatment of prostate cancer that is in the amber zone, and please correct me if I'm leading the audience astray in mentioning that prior to deciding what treatment is right for them, patients should have a consultation with both a urologist and a radiation oncologist.
Yeah, thanks, Ian. I think ideally that would be the case. I'd have to say that just from genuine personal experience, that it doesn't always work out that way. In terms of the pipeline of patients having their biopsy, that's all done by the urologist, and so the urologist is the first person to see that patient with the diagnosis, who then explains the treatment options. And absolutely, in an ideal world, the patient should see the radiation oncologist as well. Sometimes, and timing is usually not an issue, but sometimes the patient has already decided in their mind, and it's very difficult in that situation to then convince them to see another person if they've already sort of stuck in their head that they want to see you. Now, I'm not saying that's the right way to go, but I'm just saying that it often happens that way, and patients do have to be careful about that, because all of us are biased. We might like to think that we're above bias and that we're all perfect scientists. That is not correct. Surgeons are biased towards surgery. Radiation oncologists are biased towards radiation, and that's really a fact of life. And it's another reason why it is really a good idea to get that opinion from other people. I just want to also comment. Andrew really described it very well, in the fact that, the whole reason that we're having this talk tonight really is because we cannot dogmatically tell patients this is the correct treatment for you. If we could, and I'm sure there are some cancers, in fact there are certainly other urological cancers where it's very clear from the evidence base what is the most appropriate treatment. But for your classic intermediate grade prostate cancer, both treatment options are on the table, and sometimes in certain patients, particularly if they're older, for example, over 70 years of age, even sometimes active surveillance is still appropriate for that age group. If we talk about surgery for a moment, there are various surgical approaches, either the two main categories, of course, being traditional open surgery, which involves typically an incision below the belly button down towards the pubic area, or keyhole surgery, laparoscopic surgery. And nowadays, by far the commonest method of that is robotic assisted laparoscopic prostatectomy, but you can also do it without a robot. It's much more technically demanding without the robot. The robot really does make our lives a whole lot easier to do the operation. And so they're really the surgical options available. When we do the operation, just with any treatment, as in either the radiotherapy options, there are risks to the surrounding organs. So the prostate, unfortunately, is very delicately positioned in the male pelvis. So you have the bladder sitting immediately on top. You have the nerves which supply the penis with erectile function running immediately behind the prostate on both sides. And you have the urethra running through the prostate, and then you have the sphincter, which controls continence, immediately below the prostate, and of course then the rectum at the back. So you can see already it's completely surrounded by really important structures which provide that man with quality of life. So just as the radiation doctors want to be as precise as possible with delivering radiotherapy, as surgeons, we also want to be as precise as possible when we remove the prostate, wherever possible, sparing all of those surrounding organs, in particular the erectile nerves and the urethral sphincter, trying to, as best we can, preserve erectile function and urinary continence. However, both of those are at risk when we do treat prostate cancer.
Right. Can I ask, Jeremy, are the outcomes better when the robot is used and patients would have a robotic-assisted prostatectomy compared with prostatectomy that does not involve a robot?
Yeah, it's a great question, and patients ask it all the time, understandably. The robot certainly sounds as if it should be a whole lot better. I personally perform both open and robotic surgery, so I don't have a bias either way. But from an evidence-based point of view, the long-term outcomes are equivalent. So when we talk about long-term outcomes after treating localized prostate cancer, number one, of course, cancer control, but number 2 and 3, which are very close behind, of course, are continence and potency. Now, those 3 factors or outcomes are overall equivalent, regardless of the approach that you use to surgery. What is different is the very short-term recovery period. That can be a shorter hospital stay, but more often it's just a slightly shorter recovery period with robotic or laparoscopic surgery than open. And that makes sense because you're making tiny incisions with the keyhole, which are causing minimal trauma to the abdominal wall versus a larger incision. So it's very, very much analogous to, for example, an old-fashioned gallbladder operation, which was a big cut under your rib cage to remove the gallbladder, versus standard of care now is keyhole gallbladder removal, where patients are sometimes even going home on the same day.
Thank you, Jeremy. No, it's very comprehensive. Let's go back to Miranda. When men are weighing up radiation therapy versus surgery, when you're talking to men before they make this decision, and presumably also you involve the man's partner, what sort of things do you discuss, and what's your role at this stage, Miranda, in helping patients choose what treatment is right for them?
Yes, thank you for the question. Interesting what Jeremy said about patients have already often decided when it comes to that point of choosing a treatment. They often swayed very strongly one way or the other for some reason. Often men want to actually get the prostate out surgically because they feel like that they're actually getting rid of the cancer, and they haven't perhaps considered the other options. So it is part of the prostate cancer specialist nurse role is to talk to those men about the other treatment options, and also talk through with them each of those options, and the potential side effects, both short and long-term side effects, and to give them written information about it and ask them to talk to other men who've had prostate cancer treatment and put them in touch with support groups. And give them some time to absorb the information and talk to their partners and the families and try and work through what's going to be best for them at the end of the day.
Yeah, no, that's very helpful, and I think you're right. It's very overwhelming. We all know from personal experience, you know, from being in a doctor's surgery as a patient, it can be overwhelming at times, and you're given information, and you're advised to go away and distill the information, to do reading, but to, of course, obtain your information from credible sources rather than just surfing the internet without regard for the validity of the source. Very important. So thank you, Miranda. We've had a couple of questions from members of the audience regarding particular types of radiation therapy, and I know that we will get to brachytherapy in just a few minutes, but we've had a couple of questions put in from members of the audience relating to nanoknife technology and also MRI linear accelerators. Now, Andrew, does the nanoknife or an MRI linear accelerator offer game-changing capability to treat prostate cancer? Are these techniques that are commonly used in Australia, or is it still in the research phase?
All right, well, let's just define what those energy sources are. So a nanoknife sounds very similar to a treatment technique called cyberknife, but it actually is not a radiation source, Ian. So nanoknife is an energy source that utilizes electricity to treat and kill cancer cells. And so we'll put that aside to one point, but I think the question will be answered in part when we talk about focal brachytherapy, because it does segue into nanoknife. So the question then steered us towards an MRI linear accelerator, or MRI LINAC. So an MRI LINAC is certainly a relatively new technology, relatively new to Australia as such. There are about 4 or 5 MRI LINACs that are now commissioned. And so this is a device and a unit that has an MRI, if you like, a diagnostic MRI, so a unit that uses magnets to take high quality pictures, and it's blended with a radiotherapy unit. And in fact, it's one of many systems that give you a similar solution. There's also a non-MRI LINAC option called Ethos, which uses a CT scan to take very similar high quality images, and it's bolted on to a radiotherapy delivery system. So, you know, all these new twists with technology are aimed primarily at being more targeted, to minimize dose to all the surrounding healthy organs nearby, as Jeremy has pointed out, and for it to also be reproducible and accurate, because, you know, a lot of our treatments do require daily visits over a number of weeks. And so we can't just make sure that we're accurate on day one. We have to reproduce that accuracy for the 3 to 5 weeks during treatment. And the other thing is, when you start getting very accurate with how you administer the radiation, you can start then compressing the course of treatment. So traditionally, most of the radical courses of treatment would require 7 weeks or 8 weeks of commitment. More recently, particularly for men in the amber zone, we're moving quite commonly to 4 weeks. But even more recently, there is a form of very targeted radiation called stereotactic radiation surgery, where we are administering the treatment in as few as 1, 2, or up to 5 sessions, which gives us the dual benefit of similar long-term cure rates, but convenience. So you don't have to be off work for long periods of time, particularly if you don't live close to the radiotherapy department, and it requires quite a significant disruption to your everyday life needs. Now, the only way that we can really compress the treatment to short, sharp courses is when you have been able to sort out your accuracy issues. Now, there are a number of things we do, for example, in men who have, before men attend for their radiotherapy planning, we do usually obtain permission and insert little gold seeds into the prostate, which are transperineally inserted, for which the radiotherapy machine can then lock on to the gold seeds, which act as reference markers or a GPS system to ensure that within 1 or 2 millimeters degree of accuracy. Also at ICON, we have a second localizing system where we insert little radio frequency transponders that talk to the radiotherapy machine, and these are little sort of beacons that through a constant feedback loop ensure that we're hitting the correct target every sort of millisecond of a treatment course, which may typically span 6 minutes. The other thing, when I saw a question about this online as well, was that there are prosthetic devices which can be used to separate and push the rectum away from the prostate. And as Jeremy mentioned, the rectum actually touches the prostate. So you can imagine that if we're trying to kill the cancer in a prostate, there'd be not an insignificant dose of radiation that will hit the front wall of the rectum. Look, and that may cause a problem with bowel function 1 or 2 years after the event. But what we can do at the same time we plan men for their treatment is we insert a dissolvable prosthetic device, which is usually a jelly, which sits in the space between the prostate and rectum, which then gives us and pushes the bowel maybe 10, 15, up to 20 millimeters away from the radiation dose. And this has actually been something that's been commonly employed in Australia probably over the last 7 to 10 years, and we believe hasn't entirely, but has substantially reduced risk of radiation in causing bowel damage long term.
Okay. No, thank you, Andrew. Now I'll circle back to NanoKnife maybe a bit later if we've got time. But I might pass over to Jeremy. You've mentioned there a lot about radiation therapy. Brachytherapy, you explained to us before, of course, is internal radiation where seeds are injected into the prostate and give radiation therapy. Jeremy, do you want to go over to talk about some of the latest trials, including some of the trials that are continuing with brachytherapy? The Liberate trial was one we mentioned earlier that ICON is participating in. And in particular, we have had questions from the audience asking about brachytherapy's suitability for a younger demographic, or is it a treatment that is only suitable for older people?
Yeah, thanks, Ian. So perhaps if I focus on, pardon the pun, focal therapy, and I might let Andrew field the question about whole gland brachytherapy, which is the more traditional type. I think it's just worth pointing out in this forum that there is a lot of work going on in the research world at the moment on, I guess, trying to find that holy grail, if you like, for localized prostate cancer treatment, where we can basically eradicate the cancer but keep any side effects to an absolute minimum. Now, of course, we're already trying to do that with our traditional treatments, whether it be surgical removal or, as Andrew's just explained, all the techniques that we can do to minimize radiation dose to surrounding organs. But the newest way of doing that, and this is only now because we have such good imaging to show us where the cancer is in the prostate, is this idea of focal therapy of prostate cancer. Now, there are only a certain proportion of men with localized prostate cancer who would be suitable for this. You really have to have this amber or intermediate type of cancer, or possibly one of the larger types of low grade. But really the main target is patients who have intermediate grade cancer, and it's visible to the naked eye on an MRI, and the biopsy confirms that. Now, if it's in one spot, rather than treating the entire entire prostate gland and putting all those surrounding organs at risk, we can now in a very highly targeted fashion just treat that significant cancer. And what we're doing in the registry through ICON is brachytherapy as that focal therapy. And a couple of the reasons for that, we have, especially with Andrew C. and other ICON radiation doctors, decades of expertise in brachytherapy. But, from a pragmatic point of view, it's also covered by Medicare and the health fund. So it really is an ideal method of performing focal therapy. However, I do want to stress, and this is very important, this is not a current standard of care. You won't find it in any official clinical guidelines. I'm not speaking on behalf of them, but I am a panel member for the European Prostate Cancer Guidelines. So focal therapy is still requiring data collection, which is exactly what we're doing with focal therapy patients. So it's somewhere between active surveillance that we've talked about, or whole gland removal or treatment, which we've also talked about. This is almost like the middle road, if you like, for a certain number of patients. So for me as a researcher, this is extremely exciting, and for Andrew as well. We co-principal investigators of this study, and we're really hoping to find the sweet spot for this subset of patients to keep those side effects to an absolute minimum, but also not have the anxiety of perhaps there's a cancer that could continue to grow unless it is treated.
Right. No, thank you. That's a great explanation of, as you have emphasized to us, Jeremy, focal brachytherapy, different from whole of prostate brachytherapy. We're getting towards the end of the hour. If people have questions, please submit them. We may not have time to get to all questions, but we will put a transcript up on our website, and so hopefully we'll get to your questions in that way if we miss out tonight. Can I just, it would be remiss of me not to ask you, Jeremy, then could you, and then we'll go over to Andrew, followed by Miranda, but the management of cancers in the red zone. We've gone through the green zone, the amber zone. What happens if someone is in the red zone? What sort of treatments are applied or offered to those men, Jeremy?
So the short answer, and I'm pretty mindful of the time that we've got available, but the short answer is exactly the same really as the treatment options for intermediate cancer. So if we're talking about the red zone, just to specify it, it's still within the prostate, even if it's extending at the edges of the prostate, but it's a high grade type of cancer, then surgery or radiotherapy are still both suitable options. The only thing I would say from a surgical point of view, sometimes we're not able to spare the erectile nerves, because if the cancer is impinging on those nerves, then of course it makes no sense to try and preserve them, because you will leave cancer behind. And from a radiation point of view, if it's high risk, then the best evidence tells us that it requires some adjunctive treatment with hormone therapy for a period of time, perhaps around 2 years. But I can let Andrew talk more to that.
Yes. Andrew, do you want to give us your take on treatment of the red zone cancers, and also potentially an introduction into some of the pitfalls of treating cancer in the red zone with radiation therapy, and some of the side effects that we're worried about and percentages?
Yeah, I mean, fortunately, it's not as common a situation to be in most of the cancers in the green and the amber, but these are the big time cancers, the ones that potentially are a little more difficult to treat. That oftentimes will need not necessarily just one treatment, but multiple treatments, no matter whether you're heading down a surgical or a radiation pathway. And this is also an area of active research, where different techniques, new drugs, new drug combos are being actively deployed. So I think just to sort of take a half a step back, though, I mean, this is the sort of the group of men where we would significantly benefit from having a multidisciplinary input and discussion. And look, I and all of my sort of fellow urological colleagues, both radiation, medical, and surgical oncology biased, we all meet at regular intervals to specifically discuss these cases. From a radiation perspective, we would usually incorporate some form of hormone therapy with the radiotherapy in men in the red zone. And that's because even though the PET scans or workup imaging devices, imaging scans may not have necessarily shown signs of advanced disease outside of the pelvis, unfortunately, we do know and recognise that a significant proportion of these men may come back over the next 5 years with secondaries in major organs, lymph nodes, or commonly for prostate cancer, it's the bone. So hence the sort of combo effect where we, like drugs, to try and sort of street sweep the rest of the body just in case there are these little rogue elements, and some form of intensification of treatment to the prostate. And we also do know that when you do combine radiotherapy with hormone therapy, you get a better radiotherapy effect. And so there are certainly studies that have shown, in the laboratory that the two combined give you a better kill rate as such. But all the other things in terms of making sure that you're accurate, putting the gold seeds, the rectal shot, they still apply to the red zone. I think surgery is a very good option also for men, select men in the red zone, and it does certainly give us more prognostic information. Having the prostate out as such is also of value. Men who may have strong family histories of prostate cancer, younger men who are fit and don't have any risks with surgery would be well suited. But I think we go into operations and surgery in that scenario with a high likelihood that it's a very appropriate opening manoeuvre, but there's of moderate to high likelihood that at some point, even though they've had surgical removal, they'll need to come back and have, as what Jeremy's mentioned, either adjuvant or salvage radiotherapy, where the radiotherapy comes in at some point of the postoperative phase to mop up any leftover cells, and that's combined modality therapy, i.e., basically it's throwing in the kitchen sink or hamburger with the light. Again, the issues of if you add surgery to radiotherapy, then you've got the toxicities from both treatment we recognise. But, I think in that circumstance, the risk-benefit scenario still favours going harder because, this is a difficult cancer to cure. We've got sort of, one good opportunity up front to sort of get the outcome that we desire. And so, I suppose taking more risks is more relevant. But of course, once you've explained and you've counselled the patient and their family, where you think they're heading.
Mm-hmm. Thank you. And unfortunately, of course, some people do suffer side effects of treatment. Both Jeremy and Andrew mentioned incontinence, erectile dysfunction, occasionally problems with the rectum. Miranda, could I bring you at this point? Could you maybe enlighten our audience a little bit about some of the side effects and how common they are when you're seeing people following treatment for prostate cancer, and hopefully reassure us and reassure the men watching that there are various maneuvers that can be employed to help with the side effects of incontinence and erectile dysfunction after treatment for prostate cancer.
Yeah, so I'm a strong believer in prehabilitation. So I'm counselling my patients to actually start really early before having prostate cancer treatment and preparing for potential side effects after treatment. So in particular, with urinary incontinence, getting the pelvic floor muscles as strong as possible and referring those men off to see specialist men's health physiotherapists to do that before they actually have the treatment. So once they're actually performing those pelvic floor exercises and hopefully that improves urinary continence post-treatment, and they make a quicker recovery. Also with the erectile dysfunction, important that they have good function before they have treatment, and encouraging them to actually making use of that function prior to the treatment, and also getting onto medication if that's needed early on, and then giving them hope, always being positive about post-treatment recovery, and the things that can be done, and making the best of the situation. So for instance, with erectile dysfunction, talking about the oral medications that can be used in the first instance, then maybe later on injections and pumps and vacuums and implants and things like that. So always giving men hope that their life can return to as normal as possible when maintaining quality of life.
No, thank you, Miranda. And that prehabilitation, that's a great word, and a great concept to employ. And of course, pelvic floor exercises we think of mainly for women, don't we, in association with post-delivery. So that's great to remind us all about the importance of prehabilitation and pelvic floor exercises in men. We're running into our last few minutes now. I'll try to go round the panel. Andrew, just going back to you, you mentioned very briefly about the nano knife before. Would you be able to just explain again what the nano knife is, and does it have any role in the treatment of prostate cancer? And also, we hear in the lay media sometimes about proton therapy as a new way of treating prostate cancer. Is that a modality that is available in Australia at the moment?
Well, I think proton therapy is an easy one, Ian. There's currently no clinical department that offers the technology, but protons are a form of radiation. They're heavy particles. There is a proton centre that's being constructed in Adelaide, and that should be live over the next 18 to 24 months. Proton therapy has had a little bit of airplay in the States. I think there are a number of trials that have sort of looked at the clinical utility of using protons. I would say, just to sort of summarise that part of the question, I don't think it necessarily offers anything revolutionary new or a point of difference compared with standard radiotherapy techniques. I think protons certainly have had a significant impact in the management of paediatric brain tumours by virtue of the fact that the radiation dose is able to stop in or very close to the tumour, which again minimises radiation splay to the surrounding healthy organs. And in a paediatric brain tumour scenario, that is of vital importance. And I think that's sort of, the number one, I think, point of interest for where, clinicians are rubbing their hands when this system goes live. Now, IRE, again, it is an energy source that utilises electricity. And we know that electricity, when applied to a cancer cell, can pop its membrane and the cell can die. Now, how do you get the electricity into the prostate? Well, you've got to stick needles under an anaesthetic into the prostate, similar to how we do for the biopsy and for brachytherapy. And then when the needles are strategically placed in the prostate, you pass a current, and the current will do the damage. Now, IRE currently in this country is still considered to be not a standard therapy option. It's not widely available. There are a couple of IRE centres that are live in both eastern seaboard states, so New South Wales and Melbourne. It's quite expensive. There is no long-term data, but certainly as an energy source, we know it can kill the cancer. It's a current area of active research. Now, IRE is being used as an alternative energy source to manage men with focal therapy. So we're doing the focal brachytherapy trial, but there is a focal IRE implication or indication. But in fact, you can do a whole lot of other things to also achieve the same oncological endpoint. You can freeze the prostate, heat the prostate, electrocute it. You can irradiate it. Where IRE, I think, has a good value and interest in my clinical practice is it seems to be a very good option if men have had radiotherapy and 5 or 6 years down the track, there appears to be recurrent cancer in the prostate. It's actually very challenging and difficult to remove the prostate in that circumstance. And IRE has, I think, is of significant benefit to be able to retreat men who previously had radiotherapy but developed local recurrence. And that certainly is actually an indication where this treatment is offered in the hospital where I work.
Excellent. Thank you, Andrew. That is so informative. Okay, as we go around the panel now, Andrew, do you have a last word you would like to give our audience? Any last message you'd like to transmit to those viewing?
No, look, I think I'm very impressed with the repertoire of questions that have been asked online. Obviously, we have a very informed audience today, and unfortunately, we've run out of time. But I again want to say that radiotherapy does remain a very valid treatment option for men with low intermediate risk disease. It certainly has been utilised for many years, almost a century as such. That improvements with treatment delivery have really been quite substantial. So what we are doing now even is very different to what we used to do in the mid-late 90s. And so I think the treatments are safer, more accurate, more efficient, and easy to deliver. And we've improved outcomes from a quality of life perspective, as well as getting very good outcomes from a cancer control perspective.
Yes, thank you, Andrew. Mid-90s doesn't seem that long ago for many of us, but as you say, great strides have been made in cancer therapy since that time. I'll go over to you now, Jeremy. Are there any last-minute messages you would like to give our audience with respect to prostate cancer, and particularly the surgical treatment and how patients navigate this area and choosing between the various operations available?
So I guess my final message would be to listeners and potential patients out there, enormous hope. You're living in a country where we are at the absolute forefront of prostate cancer care. I can say that very confidently, having colleagues internationally. We have access to the most access, I would say, to expert imaging with MRI, PSMA PET. These are standard of care imaging that we've been actually using for years. Many other countries around the world are only just starting to take up MRI and don't even have PSMA PET as an option yet. So we're streets ahead in that regard. We're streets ahead in how we do biopsies. The majority of biopsies in Australia are now performed via the skin, avoiding the rectum and avoiding all the risks of sepsis that go with that. Where we have one of the highest rates in the world of active surveillance for low-risk prostate cancer. So we keep the unnecessary over-treatment of prostate cancer to a minimum, and thereby minimising harm that can be unnecessarily caused to men with low-grade prostate cancer. And I think the latest, most exciting thing is our interest in reducing harm even further, potentially by using focal therapy. So that's under investigation, as mentioned with the Liberate therapy. Just one final thing from a surgical point of view, almost around exactly the same time, actually, as Andrew mentioned about the great strides that have occurred in radiation. So too in surgery, around those mid-90s, early 90s, really it might sound strange, but the true anatomy of the prostate, the pathway of the erectile nerves was only just properly discovered at that time. And so you can imagine having a prostate removed prior to that time really was a bit of a dog's breakfast, and your chance of incontinence and erectile dysfunction was sky high. That has been enormously improved upon due to our much more meticulous and precise knowledge of anatomy. And then, of course, you've got all those other advances that I've just mentioned. So it's an exciting time. I know prostate cancer is not exciting for patients, but it's an exciting time for clinicians. And I have to confess myself as being able to offer, the best in world treatment options to patients in this country.
Thank you. Fantastic, summary, Jeremy. Thank you. Fantastic. Now, our last word will go over to Miranda. It's been fantastic for you to join us, and on behalf of everyone at ICON and particularly the executive of ICON, thank you for the work you do. It's fantastic to have specialised and expert nursing services in regional Australia. Certainly, it's ICON's motto to deliver the best possible cancer care to as many people as possible, as close to home as possible. And as Jeremy and Andrew have both said, we have fantastic medical services in Australia, but unfortunately, it's often much harder for those who live in remote and regional areas to access appropriate medical care. So the fact, Miranda, that you, together with the team at ICON Cancer Centre in Mackay, are providing such specialised services to patients who live in Central Queensland is fantastic. Thank you again. And if you would like to have the last word of what you would like to say to our audience about prostate cancer and living with prostate cancer.
Yeah, thank you. You're exactly right. Rural and regional areas of Queensland, of Australia, are not doing as well as the metropolitan areas by 24% less well. And we know that 1 in 7 men have prostate cancer in our region. And unfortunately, men are still actually getting diagnosed quite late. Whilst the care for prostate cancer in Australia is very good, we can improve it. And I think with early diagnosis, then early treatment, that's going to help improve things. So the Prostate Cancer Foundation of Australia is actually trying to get a screening program happening in Australia. And I think that will actually help get more men diagnosed earlier, and it will help places like rural and regional Australia and improve those statistics. So we've still got a lot of work to do, but we're moving in the right direction for sure.
Right. Thank you, Miranda. Excellent. Well, that's all we have time for tonight. I'm sure we will be hopefully back with another session on prostate cancer to talk about some of the areas that we haven't covered tonight. In particular, as we mentioned in the introduction, we deliberately were focusing on localized prostate cancer rather than metastatic disease. But of course, there have been many advances in the treatment of metastatic prostate cancer as well. For those of you who had to leave early or have joined late, we will have a transcript of tonight's video up on our website. Our ICON Cancer Care website has a significant number now of Facebook Live sessions with experts from all around Australia talking on all different types of cancers. So we view it as a very important part of what we do in that educating the public, patients, relatives, friends, etc. So please visit ICON Cancer Centre's website. You'll see tonight's recording along with others. I wish you the very best in your either personal journey with prostate cancer or the journey of a loved one. Thank you once again for joining in, and we will hopefully be with you again at the next ICON Cancer Centre Facebook Live session. Good evening.